Well, guys, let's do a little consultation on a beautiful 24-year-old. And one of my favorite parts of meeting people is assessing their face, and I love to do it while we're talking and chatting. So I'm busy with my brain computing the things that they need or might want to get done. People will always come in to talk to you about what they see on their face. It's our job as injectors to listen to that conversation, process it, and then internalize it, because we actually want to give them the benefit of our training, our aesthetic eye, and our knowledge. We'd like to look at their face and find out where can we optimize their beauty. Every face is beautiful. That's one of my favorite parts of this job, is figuring out this person's aesthetic, their vibe, where can I really enhance their beauty. And I want to make her feel so confident and so good about herself. And I can tell that she has been suffering from being bothered by her under eyes for a long time. It runs in the family, doesn't it?
It does. Just the eye bags.
It's genetics, it's hereditary. It's something where we need to be able to talk to the patient and acknowledge, but we also need to tell them when they're not a good candidate for an eye procedure. We need to make sure that we don't try to over please. Like, one of our tendencies as injectors is to be people pleasers. And you get into trouble by being a people pleaser. You need to know your limitations as an injector. You need to only do things that let you sleep at night. And you need to say no when they're a surgical candidate.
Right.
So we already talked about the fact that you have a lot of orbital fat pad that protrudes. Let's take a look right here. When I push on her eye, we can actually see, and this is a great test for you to do in the office. Depress the globe, and you can see the amount of orbital fat that prolapses forward. She's relatively young, so her skin has enough strength to hold that in, but already it's starting to show as a little fat pad. And that's the tip of the iceberg. When we see what the real iceberg looks like underground, we realize that this is truly a surgical problem that needs to be taken out in the operating room. But we can still help you.
Amazing.
I noticed that you have a little touch of heaviness of your cheeks. The apple of the cheek is hanging low. And when that happens, we get a lot of downward traction on the eye, and the fat wants to prolapse forward even more. So one of the things we can do is support the globe by giving cheek support laterally and mid-face support medially. So we'll do that with a little bit of contouring and supporting the zygomatic tissues as well as the deep medial cheek fat here. I'm going to draw that out for you. And then the other thing that concerns her is her lower face. So she has a little bit of retrognathia. She's had one previous syringe of chin filler placed. But if we take a look and we drop a line from her nose to her lip to her chin, definitely the chin is underprojected, right? We have a full almost 2 centimeters of underprojection from here to here. And that's after already having one syringe of chin filler. So we'd like her chin to pull forward almost to this extent to give a beautiful profile. And I think that we can accomplish that today with one syringe of chin filler. I noticed that she has a pre-jowl and post-jowl sulcus. So here we're going to add some volume to support this little indentation right under her mandibular ligament on both sides. And then I also want to fill this submental crease to bring her chin right out of the shadows. When the chin goes in, we're going to develop this tendency to feel jowly. So lean your head all the way back. Let's do some quick markings. One of my favorite ways to analyze a face is to mark out lines of symmetry on both sides. And I want to start with an alar tragal marking. So starting from the nasal ala all the way to the tragus. We'll do that on both sides. It's a very precise and predetermined landmark. We can be very consistent in all patients and on both sides of the face this way. And if I don't pause and decide on her degree of facial symmetry, if my hands just start working without even thinking about this face, I'm not going to have as beautiful or as precise results. So I'm a fan of drawing this out almost each and every time. You can almost do it in your mind's eye. And I used to do that where I wouldn't draw any landmarks. I'd just kind of start injecting. And having done so many injections, I feel like your hand takes over and your mind knows what it wants to do. But when we take the time to be precise, we notice little things. We notice that she's more full on this cheek, and she's smaller on this cheek. And actually that makes me stop and realize the facial asymmetry exists. Her right side of her face is full. This is the big side of her face. Her left side of her face is petite. That's the small side of her face. And that now becomes like so obvious when I see that. But if I had just started injecting, it would not be obvious. The other thing is she has two different planes of her face. When I put my finger at the mid-pupillary line on the small side of the face, I'm a full 1.5 centimeters lower. The depth is different, right? So they have a fast slope here, deeper and more recessed and more pronounced on this side. I'm definitely going to correct that, but I point this out to the patient because we have a limited amount of filler that we can use. On the average patient visit, we're not going to have an unending supply of filler. This is not like a brochure for a filler company where we get to use 5 syringes. We sometimes are limited by budget. We might get half a syringe on each side. So for me, I would like the patients to first see lift. I think almost all people want to get rid of jowling, heaviness, and droopiness first, and then secondly, to work on correction of symmetry. That goal might be different for each patient. Some patients will tell me that they prefer to work on symmetry first. So have that discussion ahead of time. Are the goals fixing tiredness, heaviness, droopiness, or working on symmetry? We can do both, but we need more filler. And we can do them in stages, so I prefer to first give you the lift and secondly give you the symmetry. I think in order to correct the orbital heaviness and to hide the fat prolapse, we'll be pulling the cheek up. We'll be lifting the jowling at the same time. So that's step 1. And step 2, we're going to treat the midface. So the deep medial cheek fat, this little triangular zone here supports the globe. The globe is almost like the ice cream on top of the cone here. If I can give support laterally and medially, it's almost like the effect of a brassiere holding the globe in place. And in that fashion, we'll be able to let the fat pad fall back in within the globe and be more hidden. So thinking about the deep medial cheek fat is very important. Smile for me. And one other thing I'm noticing when she smiles big, let's do a big smile again. I wanted to point out this little hollow, this little thumbprint impression of hollow, which is subtle, but to me it's noticeable. And that is a clear indicator of deep medial cheek fat hollow volume loss. Patients often get this when they've had tear trough filler done and the medial cheek's been ignored, and you'll see people smile and they have a little thumbprint impression right there. So when I see that in a young person, I'm always going to put a little drop of filler to help fill that medial cheek pocket. Can I have you make a little kissy face? Okay, perfect. When she does that, the reason I like to see a kissy face is because, number one, it shows me this maximum point of her zygomatic bone. So this is the junction between the maxilla and the zygomatic arch. So right in here is where I want to really accentuate her cheekbone to give that very pretty model pop. And that's going to give lift and support to the heaviest portion of the cheek. Go ahead and maintain that position for just a moment. We're going to give 2 quick little pinches to give a little touch of support medially. And then I'm going to give a bolus of about 1.1 cc's directly on the maximum point of apex of the zygomatic arch, right there. And keep on maintaining that little kissing position. And for me, this is a nice trick because it shows you the lower border of the zygomatic bone, and it gives really beautiful delineation of the arch of the zygoma, the cheekbone structure itself. I'm here injecting directly on periosteum. You can aspirate as you go if you'd like to, but with supraperiosteal injections here, you're not going to have much risk. You're going to be sure that your needle is not falling deep into a foramen, which you can literally palpate as a hollow. Right in here, she has a zygomatic foramen. Number 2 landmark is going to be dropping a line from the lateral canthus down to the zygoma, and then we'll remember that we'll see sometimes vasculature there. So zygomatic vein can be there, and zygomatic artery and transverse facial artery. So I've used about half a syringe of filler here to give a nice, beautiful contour. I'm going to also treat the upper portion of the zygomatic bone. So that was the inferior portion. Now we're going to go back and treat the upper portion. An injection supraperiosteally here is safe. You can definitely aspirate. I recommend that if you are unsure of your anatomy, or if you're a new injector, or in general, aspiration every day, all the time is a great idea. As you get to be more experienced, you'll learn with your hands which rules you can break and which rules you have to keep on practicing and following. Okay, relax your mouth there. And then let's do one last little drop on this side. And I'm going to be conservative with the amount of filler that we're going to use on a young face like this. We are trying to avoid the creation of the overfilled face in our practices and in our communities and in society in general. So conservative treatment is very important, and remembering that the filler is really going to hydrate and give a soft, beautiful appearance over time. Show the camera too. So beautiful lift and support. I don't want to do very much around her actual orbit because she does have some malar edema. Her skin is showing us a little bit of swelling right in here. That's the malar edema. And we also know that she has really significant swell tendencies. She has a lot of blue veins under her eyes. We can see this network of blue veins, which means allergy sufferer. You must probably have some allergies.
I do.
Yeah, we call these allergic shiners. So when people have a network of blue veins and a blue discoloration under their eyes, they often have allergic rhinitis, and increased sinonasal drainage will give more venous flow here and more swelling tendency. And she's already showing us she's a sweller because here's the malar mound right here. You can detect a little juicy swell here. And you can also see that this fat pad is ready to protrude at the moment's notice, like whether she cries, if the wind is blowing wrong, if you have a little salty margarita or anything.
Yes.
So listen to your patients. When they tell you and show you these things, we have to respect them. So very careful to avoid injection anywhere close to the malar mounds as well as up in there. Next up is going to be a little lidocaine to numb for the medial cheek fat injection. Lean your head back. This one stings for just a quick moment. We're going to use a great product here, Restylane Contour. 1, 2, 3, and a little quick pinch with a cannula. And again, 1, 2, 3, and a little quick pinch. And this is a wonderful filler for contouring these type of areas with minimal swelling and very soft effacement of tissue defects. So I think you're going to like how it just softly rounds that area without giving too much swell and not too much definition there. Okay, so Restylane Contour. So this is a terrific product for the mid-face area. And it's excellent for treatment of that deep medial cheek fat. This product is really not going to swell in this area, and it's a really nice rheology. It's in between, somewhere between Restylane Define and Restylane Kiss. If you've used these products before, you know that they're very uniform and very predictable behavior. And this is what we want around problematic tissues like malar edema and around the under eye. So now I'm going to have her in this position of leaning backwards. She's doing cheek. We're doing cheek contouring, so I'm following bone structure. So the positioning of the head can be backwards. I actually want to see the bone structure delineated better. Let's make a little kissy face right there, and that's going to help me localize the apex of the cheek and the very most sharp and prominent portion of the zygoma inferiorly. When I do this, I'm also palpating to feel for any zygomatic foramen and any palpable transverse facial artery pulse, which I can actually feel right under my index finger. So her blood pressure is booming, and we can feel that going right there. So it's nice to palpate and feel. I often feel as an injector that 50% of our work that we do is with our fingertips, and the other 50% is with our eyes. So by palpation and touching, pulling the skin backwards and determining where it's going to have the best vector of pull, that's very important. And feeling for where do I feel a hollow, where do I feel a recess. Those are always the points where we want to add volume, but paradoxically, these are always the points where we're going to have vasculature running through. We do that kissy face one more time. So now my thumb is protecting this foramen and where I feel a pulsation, and I'm also protecting the inferior orbital by holding in these 2 points. I kind of give myself landmarks of where to avoid. And I will aspirate and I will inject retrograde and with a moving needle. I'm going to give a bolus at the sharpest point of the apex of the zygoma, and that gives some support to lift that cheek upwards. There we go. And if you're an injector who doesn't prefer to aspirate, I highly recommend becoming well versed with cannula. I personally prefer a needle. I think it's much more precise and causes a lot less soft tissue trauma. Now remember, as we reach the lateral canthus, we drop a line 2 centimeters from the lateral canthus down to the zygoma. We can almost virtually see where the zygomatic facial vein is going to cross here. And there's always a little recess point, so that's a tendency to want to put volume right there, and the more we hit right there, the more we get a little bruise right here, as well as possible, vascular issues. So always approach it from below, aspirate, and deliver a small bolus of filler, and then roll that upwards to where you want it to be. So that's a good technique for avoiding getting into it by rolling up and around it. May have the cannula. Perfect. And as we advance forward, remember feeling for inferior rim of the orbit, 1.5 centimeters below that, the nerve artery bundle of the infraorbital nerve exits. Put our finger there and help guide the cannula upwards. That's one method of protecting. With the cannula in place, I don't aspirate through cannulas, it's very difficult too. But I make sure I'm in the correct plane. I'm going to do small aliquots of filler. This is Restylane Contour, which we used on the opposite side, and we're going to follow the orbital rim. This is the time that we'll have the patient lean their chin downwards and forward. Open your eyes, and you're going to look straight ahead. You notice when she closes her eyes, close your eyes for me, the muscles tighten up and the fat pops into the orbit. So we don't want that. We want her open-eyed. Leave your eyes open. The fat slightly protrudes. That's a real subtle thing to notice, but the more that you inject in this natural position of engagement where the patient's looking straight ahead and looking at you, the more you'll see that fat pad, and that's going to allow me to hide it better. And now we will go ahead and push on her globe so I can see where to not inject. That's a great technique, so I want everyone to learn that. And in your mind's eye, you'll remember where that is, and your cannula should stop short of it, about 3 to 4 millimeters short of that. Good. When I place my cannula entry port, I will often place it in a zone where it's going to anesthetize the branches of the infraorbital nerve. So this becomes a nerve block. It becomes very comfortable for the patient. They'll feel just the beginning and then a little bit of pressure, but not much afterwards. So learning how to do an infraorbital nerve block that doubles as the entry port for the cannula is actually an excellent technique. I haven't had much problem with that technique other than once in a while you might get a little artery branch poking that, getting the lidocaine in there, and you can get some bruising. So if you notice anything brisk or oozing, you'll put some pressure on it and you'll find a new opening site. You'll make a new opening site. Let's do a smile. Good. So now we're going to look for that deep medial cheek fat hollow and a little piriform recess where we'd like to put a droplet of filler, a little pop through that little septum. And then a slight retrograde injection technique is perfect here. Good. And then relax your smile. Excellent. And then one more time. So we're giving her some anterior cheek projection. As we age, we get very flat in this mid-face. So if we look at a patient who has a flat mid-cheek, they look older and they look more sunken. When we're rounded here under the mid-cheek area is rounded, we look more youthful. So that's one of our goals, is to create that rounding and allow that orbital fat to fall in and also let the mid-face look youthful and perky. Okay, good. And now don't smile. Excellent. So I'm adding a little bit more anterior cheek projection here in the mid-face, and I think that's going to serve her well. And then we also want to make sure that the mid-cheek connects with the lateral cheek. So I'm going to use that same entry port and come up the top portion of the zygoma. So we've enhanced the bony border. We're going to enhance the top border so that we don't have that little shelf. Restylane Contour is one of the fillers that I think is ideal to treat that shelf area. Off-label, on-label, we're treating directly in the mid-face. And that's a nice, soft, pleasing curve to her face. And she still looks 23. She doesn't look overdone. That's really critical to not create faces that look overfilled and over-contoured at a young age, because then you just start looking older, I think. So using the cannula, we'll try to guide just at the top border of the zygoma here. And then the next step we're going to do is your chin and your lip. So I felt a little pop as we pop through this septal tissue that separates the two fat compartments going from the medial cheek fat to the lateral. And once you know that you've popped through that, you're in a safe plane here. And the tip of my cannula is here under my finger, and I'm going to inject retrograde and come all the way out. Go back and forth a couple times so I can create 3 soft strands, linear strands of filler. We don't want to have lumps and bumps, and we don't want to have large depot injections, just small, thin strands of filler. This is such a fine filler. Restylane Contour is really finely morselized and comes out of the syringe in an ultra fine technique. I actually want to show you guys how thin it is as it comes out. The strands of it literally look very refined, and we're not going to use that last little bit, so there we can see those are the strands that we're creating as I place them directly in this zone in here, just like that. It should be that thin. And then placing it as it's FDA approved for the mid-face, we can create a fanning technique where it's placed just like that in the mid-face and multiple passes just like that. So that's going to be thin. It's going to tissue integration is going to be excellent. The soft rounding of the face is going to be excellent. It's got great cohesivity, and it's not too strong of a filler for a thin, delicate tissues like yours. So in looking at her face, she has a bit of an underbite. Show me your smile, and show us your teeth, your bottom teeth also, so we can see an underbite. Yes, and so we want to really overcorrect her chin, remembering to look at the chin in 3 dimensions, so it's not just a flat structure. We always think of it 2-dimensionally. And my favorite aspect of looking at the chin is this AP, anterior-posterior projection, is so important. I like to mark the midline, so we'll do that. Your easiest way to mark the midline is to follow the columella. And in her case, she has a pretty symmetric lower face. So we'll mark the midline here, the midline there, about 1 centimeter on each side of the chin. Here, 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 here. Okay, perfect. And then the width of the chin should be petite. In her case, we'd like the width of the chin to match the width of the nostrils, here to here. It doesn't always have to be this exact size, but for the majority of women, that looks most feminine. I will also measure in terms of mid-face proportion and forehead proportion. So she is measuring about 5.5 centimeters of her forehead. Her mid-face also, from brow to nose, is the same, 5.5 centimeters. From pupil to lip, 5.5 centimeters. She's very precise in that aspect, but when she was born, she got a little petite chin of about 3 centimeters, so that's why things feel a little bit off proportions, and that's okay. We have the technology. We can improve on that. So I think lengthening is going to be one important aspect. Projecting is a second important aspect because she's slightly under-projected. We noticed before that her chin is slightly blunted on her side profile view. She's slightly blunted in, and it's going to look nice to bring that outward to match her nasal proportions better. So Restylane Define, being FDA approved for chins, is an ideal product for this area. We're going to give a small bolus of filler. I am going to aspirate here. Staying directly in the midline allows me to be in a very avascular plane. And I'm going to slightly over project that chin initially, and then the filler is quite malleable. We're going to massage and distribute and make sure that it sits very symmetrically. Always patients will have some chin asymmetry, and we're noticing here chin dimpling. This can be treated with some units of toxin, which is going to relax that blunting. Patients who are missing some chin volume will naturally have a tendency to blunt and pull inwards with their mentalis muscle, and she really is doing that constantly at rest, and she's not even aware of it. So I like to mark that now, because once we put some filler in here, this area is going to be anesthetized and those muscles won't dimple anymore, so it'll be harder to put toxin in it. So go ahead and pop your bottom lip out and protrude it. And that's the best way to show the dimpling and indentations of the mentalis muscle. So I'll mark that now, where I plan to put some toxin, neurotoxin later. Show me your bottom teeth. Good. Now remember, this is going to be the zone of our DLI. Again, your bottom teeth. Here you go. Right in here. Make a pout, and that's the DAOs right over here. So got to be careful when we're injecting neurotoxin for the chin to make sure that none of the fibers that interdigitate between the DLI and the mentalis are going to be knocked out. As a beginner, and even to this day, once in a while you'll put toxin in the chin and you'll knock out a little bit of the DLI muscle, and the smile will be asymmetric. So I always recommend to check by asking the patient to protrude their lip. Protrude it. Okay, relax it. Show me your bottom teeth. That shows you your DLIs. Make a pout. Next up is palpating on either side of our initial bolus, and let's add some volume. So right where we've marked where the dimpling is maximized, that's where I'm going to want to add volume. I like to myomodulate this musculature. The muscles are tensing in so much because they don't have any underground support with bone structure. So let's give them some underground support with filler structure. And each bolus here is 0.1 to 0.2 cc's of filler volume that we're placing. And I am also going to place some at her pre-gel sulcus. One of the things that I noted when she first came in, which is already looking better, is that she had this little indentation on either side of her chin. And to me, that distracts from the overall jaw beauty. So I'm going to go right under her mandibular ligament. And this is a danger zone because branches of the facial artery and the facial artery itself cross here. I'm giving a bolus under the mandibular ligament, and that's going to immediately improve that contour in the pre-gel. Let's do that again on this side. So I'm palpating for pre-gel sulcus. I can feel facial artery pulsating under my thumb. My fingertip right here feels the ridge of it. And I'll hold it off to the side, and then I know exactly where I'm headed into. A little pinch, an aspiration to be sure we're not anywhere near an artery, an angulation to get under the mandibular ligament, and then a bolus. And then often a bigger bolus than you think, and a massage to get it to set just right. Let's do one more time right over here. Same thing again. This is a sensitive area, so I'm right here directly on periosteum. I'm aspirating. I've palpated for facial artery, which is right behind me here, and now I'm giving a bolus directly under mandibular ligament. This is going to give such excellent support to the downturns of the mouth, for jowling, and for corners of the mouth that turn down. This bolus is everything. This really helps to improve the myomodulation of this area. That's lately one of my favorite areas to treat and improve the downturn of the smile, and also just to get rid of this pre-gel indentation that we often see in so many faces. A little massage there, and then next step is going to be a little touch of toxin. Okay, pop your bottom lip outwards. And she's so strong that she's still dimpling. And we already had marked her DLI, so I'm just going to give about 3 units, 3 units, and 3 units. One in the middle, one on each side. And over time, that's going to improve tremendously. And then we may even give more, but I want to go slightly, let's also give 1 unit and 1 unit in here. Slightly conservative, because I want to make sure we don't affect any lower lip smile function. Okay, relax. Okay, and show us your smile. Actually, one thing we really wanted to work on was her gummy smile and upper lip eversion. So she has a smile that reveals a lot of gingiva. Smile again really big. When she laughs, tickle, tickle. More so on the right than the left. Do we see this right side sliding up? Almost showing your tooth roots. So does that bother you in photographs? I'm sure.
Oh, 100%, yes.
Yeah. So one thing we can do in treating her upper lip is to place volume in her piriform aperture area because she's missing some maxilla here, and that will actually help her lip to come down lower, particularly more on this side. So sometimes treating the lip is not just treating lip, it's treating all the surroundings of the lip. But we're going to go ahead and give you some Gummy Smile Botox. So do a big, big smile for me. And relax down, and then relax your smile, and now big smile. So I'm just kind of gauging and assessing where her muscles are pulling up the highest. And the levator muscle here pulls higher on the right than the left. Let's do one more big, big smile. 1, 2, 3, and a little pinch. So I'm doing about 2 units on each side. I'll probably do about 3 on this side. The LLSAN muscle here is giving her more exposure. I also will do a little bit of a lip flip because when she smiles, her muscles rotate inwards. Smile for me. And then relax your smile. At rest, she has good pink show. When she smiles, they evert inwards. So I want the orbiculus muscle to uncurl. And I'll do that after we do your lip filler because this will start oozing otherwise. Okay, here we go. A little quick pinch. So Restylane Kiss for her lips is an ideal filler. It's going to give beautiful volumes. I'm going to use the technique of coming in directly to the Cupid's bow. My first injection point almost always with my lips is to define the Cupid's bow, and I'm a big fan of an extremely slow injection technique. Slow and fine and precise hand movements. I'm almost letting the filler come out on its own, and I'm just gradually moving my hand. And that is one of the keys with being a good injector, is developing enough fine motor control that you're literally like piping and icing right out of on a wedding cake and making beautiful even tracts of filler as I do this. I want everyone to get in the habit of visualizing in your head the chain of filler that's coming out of your needle tip. I'm coming in here quite superficially in order to create some thin strands of filler, and I'm going to use a fanning technique in the corner of the mouth because I want to grow some more volume at the lateral lips. I'm going to come in on this side here and create a little better Cupid's bow. So I've already created one arm of the Cupid's bow. Now let's create the other. I like to create a sharp apex, and I'm staying within the vermilion border of the lip. I'm going to grasp the lip and guide where I want the filler to go. This is so important. Filler is a liquid. We're practicing fluid dynamics, and it's going to spill everywhere it wants to go unless I pinch and guide. So that's another favorite tip of mine, is you need to direct the flow of the fluid. So find the apex point of the Cupid's bow, giving a little pinch. You can do an aspiration if you're not sure of your depth. This is quite superficial, so I'm pretty sure of my depth. And then I'm going to inject a retrograde linear thread, super slow and ultra fine. And I'll do the same thing coming into the apex, almost coming in exactly at the needle length here. So I want to prick the lip as little as possible. The littlest amount of lip trauma is critical. We want to avoid touching the lip as much as possible. The prettiest injections have the least trauma, and they come off the needle looking like we haven't really bothered her. She just turned pretty. Prettier. Okay, and relax your smile. As we go, when things are oozing, we're going to close the ooze with our fingertips right there. Just in little finesse things that we do to make sure the injections turn out great. Patients appreciate that extra attention to detail when we help them to not bruise and help them to leave here feeling pretty and not awkward. I'm going to give a little bit extra on this limb of the Cupid's bow. Let's come in at the corner and superficially place some fanning linear threads. 1 thread, 2 threads, and 3 threads. And that is plenty. And keep your eye on the syringe, so we were almost exactly at the halfway point. Remember, her upper lip was so much thinner than her lower lip. So I've given her a little touch more than half here. I also would like to go ahead and give her a slightly better philtrum. Pulling the philtrum up and out improves the pink lip eversion of the upper lip. So I'm going to come in at a V-shaped angulation. I want to make sure that I don't draw philtral lines that are straight or perpendicular to the lip. We want to always be tented inwards. I'm going to visualize the direction of where I want this philtral line to go, roughly like this, to match the other one. I'm going to come in at the apex of the Cupid's bow, directing my needle towards the philtrum. Here we can aspirate to make sure we don't get a philtral artery. Pinch and allow the fluid to flow right between my fingertips and right out to the Cupid's bow. So if you direct the flow by pinching, we can actually create a nice little philtral column, and we can shorten a long upper lip slightly with the use of fillers. Smile for me. When she smiles, it's better, but it still sure wants to rotate in, so that's where neurotoxin's going to come in. We're going to place that on the borders to outwardly evert the upper lip. Okay, open for me. And then let's visualize what we want to do with her bottom lip. We see asymmetry of the bottom lip. This side is thinner, this side is fuller. As you look at your patient's lip, always account for that. And almost always this is going to be related to a problem in the dentition. So if I look at her lip over here, we notice that one tooth protrudes. If we look at her teeth and the dental arch, we see that this protrusion of the bottom lip is actually truly that tooth that's protruding. And this recession of the lip is actually where the teeth recede. So it's interesting, but the more I do lips, the more I realize that the dentition is everything. Yeah, and we can correct for the dentition, but sometimes we have to just have the dentition fixed. All right, here we go. Open your mouth just a little bit. So one way to get this lip to be more equal is actually placing some volume here. She has recession of her lip where the lower incisor has some volume loss at the root of the tooth, and the mental foramen, there's depression. So I'm going to add a bolus of filler here, and that's going to actually help with the lip eversion. So 1, 2, 3, and a little quick pinch. Good, just like that, and just like that. And that's going to help that lip to pop forward, to giving that little touch of support. I hope you guys can visualize that, because I saw that come out, and I think that looks good. I'm going to save the rest of this filler for the actual lip, though. So we're going to come in and staying in a superficial plane. Injecting along the outline of the lip is a great first step. If you want to have a foolproof technique where you're always going to have patients look natural and have nice results with low risk, we're going to want to inject right at the border of the lip and aspirate, and then inject retrograde linear small threads. Good. And remembering your vascular anatomy, your inferior labial artery here is going to be deep. So if you're staying superficial here directly at the vermilion border, and you're not violating the vermilion border, and you're staying within the white line of the lip, we're not going to get problems with filler migration. We're not going to get problems with vascular occlusions. And I always want to emphasize that this is the safest and easiest technique to do lips, just following the outline of the lip. I am going to give her a small bolus here, so I'm going to go slightly deeper, aspirate, and add a little bolus of filler right where she seems to be thinner on the left side of the lip. And she's a patient who can easily come back and do a second syringe of filler. 1 syringe per month till we reach our goal size is reasonable. I would also like to place a little touch of filler at the oral commissures. This is an area we routinely neglect, and the upper lip rotates inward. So if we give a droplet of filler here, it is definitely going to provide a fulcrum or bolster of support here that allows the lip to rest on itself. So that way it won't rotate inwards as easily. All right, I love that. That looks fabulous. And then our last step will be a little lip flip, putting on a touch of antibiotic ointment here just to make sure things stay nice and clean. Lean your head back, and then pucker. There you go, relax. So I'm just going to give her 2 drops of neurotoxin, and literally these are 1 to 2 units, and they're going to allow the muscles of the lip to lightly evert outwards and show more of that pretty pink of her lip. Primarily I'm focused on the outside border of the lip. I think that'll look really pretty. There you have it. That is a very nice full face transformation on someone who is so pretty who didn't even need anything.
Thank you. Thank you.
These techniques are so helpful. This was a very difficult under eye. In your practice, I might even suggest to not do anything there because sometimes you'll get phone calls and you have to be prepared for them. So you have to be super confident that your injection technique was done in all the right areas, that we supported her cheek, we helped her midface, we didn't go anywhere near her orbital fat pads, and we really respected the anatomy here. In spite of all of our best efforts, we may still get sometimes some under eye swelling. And as long as we've chatted with our patients about it, and they know how to do lymphatic massage, they know how to avoid salt, alcohol, and heat, take your antihistamine, and be a good girl.
Amazing.
It'll
I
all
can do
turn
all
out.
that.
Okay, that's it.